good evening to everyone. So today I'll be doing a bit of revision on physics, especially equipments now. Okay. Mainly I'm going to talk about temperature and hemodynamic monitoring, cardiac output monitoring, and I will do a very quick revision on ECG and heartline BP. I'll run through very fast on all that. Okay. So first about temperature, the opening question in Viva will be asking about you differentiate what is heat versus temperature. So heat is an energy form. Okay, the heat energy, if you look at this stove here, the heat energy from the stove burner warms up the water. Okay, but where the temperature is the measurement of the heat energy. The thermometer measures the temperature of the water. Okay, one is a measurement, one is an energy. So if you look at it, the heat is transferred to the object. The stove heats the pan. The temperature actually measures how hot or cold is the object is. So if you want to define, heat is a form of thermal energy. Okay, it's an energy associated with kinetic motion of molecules within a substance. So let's say you have a pot of water. When you heat it up, that will cause the molecules inside, the water molecules, to gain kinetic energy and move around. So that's a thermal energy. Whereas temperature is a measure of the heat energy level. It tells us about the thermal state of a substance. It is the degree of hotness of a substance, and it reflects the potential for heat transfer. Okay, the temperature actually tells us the potential of the heat. So if you look at it, the heat is the cause, okay, and temperature is the effect of the heat. Heat energy can transfer from a hotter to a colder substance. Okay, heat loss, when one substance lose the heat, another substance will gain. As we all know, energy cannot be destroyed. It only can be transferred or transformed. So here the heat loss to heat gain is from one area. When the heat is lost, it is gained by another area. Okay, so heat energy raises the temperature of the body. Temperature wise, temperature decides the direction of flow of heat. Okay, it always moves from a higher temperature to a lower temperature. The places which contains a more heat energy will transfer to the place with the lower heat energy. So heat flows from a higher temperature to a lower temperature. Heat is measured in joules or calories by a calorimeter indirectly, while temperature is measured directly in degrees Celsius or Kelvin by a thermometer. If you take as a unit, temperature is a fundamental SI unit of Celsius and Kelvin, whereas heat is a derived SI unit. Okay, I'm not covering SI units here, but you have to know the fundamental base 7 SI unit by the mnemonic of SMAC, SMMACK. You all can see in the podcast lah. Okay, you have to know that it will be asked. You have to know what are the 7 base SI units and what is their what are they measured in. Okay, so next we bring it to thermoregulation. So we talked about heat and temperature. So how is the heat and temperature is controlled in our body will be a thermoregulation. So the organ that is involved is hypothalamus. Your thermoregulatory center is in hypothalamus. I'm not going in detail about thermoregulation. What we have to know for exam purpose, I'm just going to let you know that much. So we have receptors, one in the central, and we have receptors in peripheral, in skin, joint, so the tissues and everything. So when there is change in heat or temperature, will be picked up by receptors. There are few types of temperature receptors you have to know. You can read in a podcast about it. We have warm receptors and cold receptors, which is Ruffini versus Crosset. I didn't put it up here. The warm receptors are actually Ski fibers. Cold receptors are A delta fibers lah. Okay, so these are the receptors involved in the temperature. Then these impulses will be sent over to the thermoregulatory center in hypothalamus, and based on the temperature, the hypothalamus will take into subsequent effect, whether need to gain it or lose it. If the patient is having a higher temperature, there will be a thermoregulatory mechanism to lose it and bring back the temperature to normal. If the temperature is low, patient is having hypothermia, there will be a heat gain mechanism to gain temperature. Okay. So we have anterior hypothalamus and posterior hypothalamus. Anterior hypothalamus is involved in the heat loss mechanism. Whereas posterior hypothalamus, it is involved in the heat gain and reset point mechanism, bring you back to the temperature to the reset. It means it bring you back to equilibrium. That is the posterior hypothalamus. That is extra info. Okay. So next, what is the mechanism that occurs? So when we have a change in temperature, your thermoregulatory center will start off a few autonomic thermoregulatory response. It's all under autonomic control. Your thermoregulatory response is under autonomic control. Okay, so when we have these temperature changes in our body, so our body will take into few autonomic responses to bring it back to the reset point. So from the peripheral and central thermoreceptors, your hypothalamus receives the impulse. If the patient is in high temperature, hot situation, there will be a temperature reduction mechanism. By sweat glands will get activated, you will lose sweat. Okay, that by losing water, you will get evaporated, then you will lose heat. And then it causes vasodilatation at the periphery. When your vessels are vasodilated, heat will be lost to periphery more easily. More blood flow to the peripheral circulation and heat is lost. Okay. So, and then if the patient is in cold, there will be temperature generation mechanism or heat generation, heat gain mechanism via brown adipose tissue or somatic muscles. Okay, that is where we have two types of thermogenesis. We call it thermogenesis, whether we call it a shivering thermogenesis or non-shivering thermogenesis. When you're on cold, your muscles will shiver. That is a shivering thermogenesis. Non-shivering thermogenesis will be your increase in metabolic rate to increase the heat. And also we have some behavioral thing to in both heat loss and heat gain, they have few behavioral mechanism to increase or reduce the heat as well, like putting on more clothes or taking out clothes. Those who have cold will walk more to increase the basal metabolic rate, and all these are behavioral components. So we have autonomic component and we have a own behavioral component as well. Okay, so these are the mechanism that involved in thermoregulation in heat gain and versus heat loss. In heat gain, the thermogenesis, you must be able to differentiate the shivering and non-shivering thermogenesis, where the shivering thermogenesis is by autonomic efference, the heat production is up to 5 times. Whereas the non-shivering thermogenesis, by increasing basal metabolic rate, it is around 2 to 3 times. So the shivering thermogenesis actually can produce more heat, but at the cost of increased oxygen demand. Okay, so that's why hypothermic, we don't want to keep patient hypothermic because patient will shiver intraoperatively, everything. We keep the patient warm, because if the patient is cold, they will shiver. That will increase the oxygen demand. That is not good for their anaerobic respiration. So next, bring us to temperature control. When we talk about temperature control, we have to know about few terms. So what is defined? In Viva, it will ask us define hypothermia. So hypothermia is talking about core temperature of normothermia of 35.5 to 37.5 degrees Celsius. This is normal temperature for human being at sea level at the ambient temperature. Okay. Core body temperature less than 35 degrees Celsius will be defined as hypothermia. Core body temperature of less than 35 degrees Celsius. So from that, we have a classification. Mild is 32 to 35 degrees Celsius. Moderate is 28 to 32 degrees Celsius. Severe is less than 28 degrees Celsius. I've listed few significant effects of hypothermia. When your temperature is 30 to 35, from 35 to muscle weakness, it goes to 32, you'll get mental confusion. Below 32 up to 28, you will be loss of consciousness, and below 28, you will get fatal arrhythmias, VF, and also can go into cardiac arrest. Okay, that's why in ALS, when a patient is hypothermic, let's say a patient found in a river, drowning patient, everything, if their temperature is less than 28 degrees Celsius, you cannot stop CPR. Okay, you have to actively rewarm the patient and continue the CPR until the temperature is above 32 degrees Celsius, because it is a reversible cause. You cannot give up. Okay, so active rewarming is very important. Next, there is another different entity where we talk about perioperative hypothermia. Okay, hypothermia, this is in a non-operative patient, in a normal people like us. We are not going into OT, not anesthetized and everything, okay, or not going into the operation theater. We are not in the perioperative period. But when you're in a perioperative period, this definition or this classification, the range differs a bit because under anesthesia, our thermoregulatory mechanisms are severely altered. We are not, because of anesthesia, your thermoregulatory response is being altered or compromised. So the temperature values to define perioperative hypothermia is at the higher level because we can't let the patient to go into lower level and they will suffer even more disastrous complication or consequences of hypothermia post-operatively. So in perioperative hypothermia, it is mild is 35 to 35.9, moderate 34 to 34.9, and severe is less than 34 degrees Celsius. That's why if a patient temperature is less than around 34 degrees Celsius, we will never extubate the patient. We will rewarm the patient at least up to 35, and then only we will extubate the patient. Okay, this is if the examiners ask you, do you know any differences between normal hypothermia versus perioperative hypothermia? You have to mention the level is higher in a perioperative patient, mean the threshold is lower towards to take action, whereas in a hypothermia in a normal patient, the threshold is higher. We can wait a bit more longer, means like we can before any disastrous complications occur. Whereas in perioperative, you cannot let the patient to dip the temperature too much because the consequences is even more disastrous. Next, very briefly about hypothermia, when it's core body temperature more than 38. Here we don't classify as mild, moderate, severe. Fever is more than 38.3. That's why in ICU, until it's 38.3, we don't take any action. Hyperpyrexia is more than 40, and life-threatening is more than 41.5 degrees Celsius. That's all for hypothermia. I'm not going to talk much on it. There are concept of heat collapse, heat exhaustion, and severe is heat stroke. This is mentioned in podcast or a small paragraph. You can read about it. Very unlikely or very slim chance this will be asked detail in Viva. They might ask you about this, and then you can able to mention the heat collapse, heat exhaustion, heat stroke is more than enough. Complications of hypothermia and hypothermia, you should be able to list it out few. Hypothermia, not much. I'm just going to leave you all to read. I will share this. Hypothermia, yes, as I mentioned, shivering thermogenesis, hyperglycemia, hypovolemia, hypokalemia, and hypomagnesemia, bradycardia, patient get into coagulopathy, reduced drug clearance and leading to overdose and toxicity, immunocompromise, increases the infection rate. Patient can have pressure sores because of reduced circulation, and eye confusion, coma, and death. Because when you have hypothermia, you will go into vasoconstriction. So peripheral cell death can occur. That is leading to SARS. And very severe hypothermia, as I mentioned, can lead to fatal arrhythmia and also arrest. So you should be able to mention few components, complication of hypothermia, and especially hypothermia. So that brings us to temperature homeostasis. When we talk about temperature homeostasis, there are three important definitions that you have to know. Okay, first is thermoneutral zone. What is thermoneutral zone? Thermoneutral zone is an ambient temperature. Please focus that I have highlighted ambient temperature. It is ambient temperature, not core temperature. Ambient temperature range over which normothermia is maintained without any changes to basal metabolic rate. The oxygen consumption VO2 is minimal and steady. It means within this ambient temperature, a person can maintain the body temperature without any increase in body heat production or loss. It means there is no activation of thermoregulatory mechanism. This is the ambient temperature range over which thermoregulatory mechanism is not get activated because it can maintain normothermia within this ambient temperature without any changes in basal metabolic rate and any thermoregulatory mechanism. The VO2 is minimal and steady because basal metabolic rate is maintained. Okay, so these numbers you have to know. In an adult male, in a naked 70 kg adult male, don't ask me why naked 70 kg. This is the value given in book. Whereas female, it will be slightly higher because of the hormonal differences. So it is 27 to 31 degree in adult male. You don't have to mention naked also, never mind. In an adult male, it's 27 to 31 degrees Celsius. As the age goes low or very elderly, the range is, the threshold is even lower. Okay, means like you cannot wait. The gap, the range between the gap is even shorter before the thermoregulatory mechanism get activated. The gap is bigger, it means you are healthy, you are better. Your body can maintain normothermia over a wider gap. When the gap becomes smaller and smaller, you cannot afford to lose or gain heat too much. Otherwise, your body will start your thermoregulatory mechanism, your basal metabolic rate will go high, and you will use oxygen more. Okay. So in an adult male, it's 27 to 31 degrees, a gap of 4 to 5 degrees Celsius. In kids, it's 32 to 34, around 2 to 3 degrees Celsius, but at a higher range, higher temperature. In infant, it's even higher, 34 to 35 degrees Celsius, around 2 degrees Celsius only. Okay, so these are the values that you have to remember. This brings us to a next definition of critical temperature. Critical temperature is related to thermoneutral zone. Okay, this is also an ambient temperature. Critical temperature is merely the lower limit of the thermoneutral zone. We have seen the range of thermoneutral zone here. So the lower limit, the 27, 32, 34, the lower limit of a thermoneutral zone is called as the critical temperature. It is also ambient temperature. Please note that. It is the lowest body temperature before heat gain mechanism start. Okay. Here we talked about heat gain here and heat loss here. That is thermoneutral zone. The upper end and lower end. The upper end and the lower end. Whereas your critical temperature only talk about the lower end because it talks about the heat gain mechanism starts. So in an adult male, it's 27 degrees Celsius, kids is 32, infant is 34. When a pram baby, when they have a very few, when their thermoregulatory mechanism is not properly evolved, they have a very small body mass and everything, their critical temperature is even higher. It means even at the slightest loss of temperature from the normal temperature of 37 or 36.5, they will start having thermoregulatory mechanism start to heat gain. Okay, that is why we cannot let the babies who come to OT, especially pram babies or very small baby child, everything, we neonates and everything, we will wrap them properly to make sure they don't lose heat at all. Because the moment thermoregulatory mechanism get activated, they're going to use up more oxygen, which is basal metabolic rate going to go high, which is not good for the homeostasis. Next is, this is another important, which is interthreshold range, which is totally different from thermoneutral zone because this talks about core temperature. The thermoneutral zone talks about ambient temperature range. This is talking about core temperature range over which no autonomic thermoregulatory mechanism response occur. So this is talking about the core temperature over which the autonomic thermoregulatory response does not get activated. It means you can maintain your temperature. Okay, this is your core temperature range over which your heat in your body can be maintained without activation of thermoregulatory response. Okay, this is something like autoregulation when we talk about cerebral blood flow, right? Within 50 to 150 millimeter mercury MAP, your blood flow to the cerebrus is maintained. This is the same concept, but in here, this is a temperature range. Over this temperature range, your thermoregulatory response is maintained. The autoregulation is maintaining the homeostasis. That's the concept of it. So this differs in a anesthetized versus non-anesthetized patient. Just give me a second. Okay, so in a non-anesthetized patient, the gap is wider. Okay, the gap is 36, 37. Sorry, the gap is shorter. It means the patient thermoregulatory mechanism is good. Okay, they can immediately activate the thermoregulatory mechanism to maintain the temperature, maintain the homeostasis, which is 37 degrees Celsius plus minus 0.2. It means from 36.8 to 37.2, if there is any change of temperature, let's say it goes below 36.8 or it goes above 37.2, your thermoregulatory response, the autonomic thermoregulatory response will get activated and your body will regain back the reset point to your temperature. It is slightly higher, 0.3 to 0.5. In male is 0.2, in female is 0.3 to 0.5 difference. I mean plus minus 0.3 to 0.5, higher in female, sorry for the typo here, because of the hormonal differences. Okay, this is anesthetized patient. It means in a non-anesthetized patient, a slight differences or slight fluctuation in the temperature also will activate your thermoregulatory response and patient will regain back, will come back to your normothermia. Whereas in an anesthetized patient, you have to actually wait until the temperature drop up to 34.5 degrees Celsius and below, or actually patient having fever 38.3 degrees Celsius and above before the thermoregulatory response get activated. This is what I mentioned. In anesthetized patient, your thermoregulatory mechanism is got compromised. Okay, it'll get compromised. So in the anesthetized patient, it's 37 minus 2.5 at the higher end, at the lower end, and 37 plus 1.3 at higher end. So the gap is 34.5 to 38.3, meaning from 34.5 to 38.3 Celsius, the patient will remain without any activation or thermoregulatory mechanism to reset the temperature. There is no heat gain, there is no heat loss. Unless it goes below 34.5 or it goes beyond 38.3, then only the thermoregulatory mechanism will get activated. This is the problem in anesthetized patient. That is why we can't let them to get hypothermia, because if we let them to initiate their own thermoregulatory mechanism, it has to be beyond 34.5, which is in perioperative hypothermia. It is a severe hypothermia already, and it can cause disastrous complication of hypothermia in a post-op patients. So this is the thermoregulatory mechanism and the interthreshold range. So if you take in a non-anesthetized patient, you see the gap is very small. Please look at my arrow here. You see it is from 37.8 to 38.2. This is the interthreshold range in a non-anesthetized patient, where anything above 37.2, heat loss mechanism start, vasodilation, sweating to lose the extra heat. Below 36.8 is already considered hypothermia. The thermoregulatory mechanism get activated and patient develop vasoconstriction, non-shivering thermogenesis and shivering thermogenesis to regain back the heat. Whereas in anesthetized patient, it is widened. The gap is widened before the thermoregulatory mechanism get activated. So it is 37 to up to 34.5 here and 38.3. The interthreshold range is widened here, okay, before any mechanism of heat loss or heat gain is started. So interthreshold range describes the lower and upper limits of core body temperature. Core body temperature, interthreshold range is core body temperature between which no autonomic thermoregulatory effects are triggered, activated. Core temperature above this range, body will initiate cooling measures such as sweating and vasodilatation, heat loss. Core temperature below this, vasoconstriction and shivering will commence. This is heat gain, this part. Under anesthesia, this widens the ITR, interthreshold range. Core temperature needs to be much lower than in the awake patient before homeostatic warming methods are triggered. The autonomic responses are triggered. So it has to be even lower. The patient will be in severe hypothermia before the body can initiate their own autonomic responses. That's why we don't let the patient to go until we warm the patient actively intraoperatively. Next. So we were so concerned about the heat loss under anesthesia in a perioperative patient. So what are the mechanisms? How does the heat loss under anesthesia occurs? So causes of hypothermia under anesthesia is because altered responses due to heat loss due to anesthesia, the lack of shivering. The shivering only comes when the temperature goes below 34.5, late shivering thermogenesis. Increase heat loss to environment exposure because the OT temperature is usually very cold. Okay, so your body is higher temperature, environment is lower temperature. There is a heat loss from your body to the environment. Cooling effect of cold anesthetic agents and intravenous fluid. That's why we actively warm the fluid. You can feel our circuit be warm with the HME. We make sure our fluid, our gases that goes in as a warm fluid, warm as well. So that is if it's a cool effect, if you have a cool intravenous drip, that will bring down the core temperature and also reduce the patient core temperature as well. And reduce heat production due to reduced metabolic activity. Patient is totally anesthetized. Patient is not moving. There is no muscle movement. There is no metabolic activity. Patient is at rest. So basal metabolic activities are exothermic reaction which produce heat. When there is no basal metabolic activity, there is reduction of heat, then reduction of heat production as well. So the heat loss under NS occurs in few phases. So this is the graph that you should know to draw. So the idea is you have a phase 1, phase 2 and phase 3. Phase 1 is the rapid decline where over the first 2 hours, you can see the first rapid decline. Phase 2 is a linear decline with time over 2 to 4 hours and finally plateau after the 4 hours. Okay. The temperature drop is significant over the phase 1, okay, from 37 to up to 35.5. Then over a certain period, a longer period, it drops another 2 to 3 degrees. Then after that, it becomes plateau. So what happened in phase 1, phase 2, and phase 3, we're going to look at it now. So you should be able to draw this graph. The first rapid decline, then a linear decline, then a plateau. So it is a triphasic pattern. First, phase 1 is because of redistribution. First, rapid decline in temperature. Vasodilatation leads to warm blood reaching the peripheries. Our core blood is warm. Our peripheries are cold. So when you give your anesthetic agent, so vasodilatation is caused both direct effect of anesthetic agent and indirect consequences of lowered vasoconstriction threshold. Okay, because under anesthesia, your autonomic responses are down. So your vasoconstriction is down as well. And top of that, you are giving anesthetic agent. Most of your anesthetic agent, be it inhalational or intravenous, all causes peripheral vasodilatation. It reduces your systemic vascular resistance. Thus, more blood from your core circulation, central circulation is redistributed to your peripheral circulation and pooling of blood in the peripheral circulation. And thus, heat loss occurs more. So this is redistribution phase. That's why the rapid decline of first phase, okay, temperature in first phase. This is the reason why we have to warm the patient even before we induce the patient. We put on the patient on a warmer. We warm the patient. We make sure even the peripheries are warm. So when the peripheries are warm, the core temperature and the difference between core and periphery temperature is not much. So there is not much of redistribution of heat from core to periphery. That is the idea that I always say. When the patient comes into OT, immediately put in the warmer. Don't start the warmer after you induce the patient. The moment you induce the patient, the redistribution already started. Then you have even difficulty to rewarm the patient to a set point. So that is phase 1 is because of redistribution due to a vasodilatation effect. Next, second is phase 2, which is a linear phase. Heat loss exceeds heat produced from the metabolism. This phase is just because heat loss is occurring. Okay, because of various mechanisms, we look into that, the mechanism of heat loss. Whereas the heat production, patient is completely anesthetized. There is no metabolism going on. So the heat production is lesser and heat loss is more. So the metabolic rate is reduced 15 to 40% under GA. The reduced heat generated coupled with increased heat loss during anesthesia lead to a negative heat balance, hypothermia. So this is purely heat loss leading to heat loss exceeding the heat production. Okay, redistribution due to vasodilatation. Here, heat loss being more than the heat production. Next, finally, is the plateau phase. Plateau phase once the core temperature falls below the thermoregulatory threshold. This is when we have talked about 34.5. Okay, so yeah, just go here to just show this part. 34 point. I said our below 34.5 and anesthetized, your thermoregulatory response will get activated. So this is when if we haven't rewarmed the patient. If the patient temperature already reached up to 34.5, your thermoregulatory response will get activated, and then peripheral vasoconstriction increases, act to limit when the peripheral vasoconstriction increases, the temperature in the periphery become higher. So the differences between core to periphery is become lesser and less heat loss from your core to periphery. Okay, so when core heat production equals heat loss to the periphery, core temperature reaches the plateau. This is if you are not warming the patient. Okay, this is heat loss under anesthesia, which is a triphasic pattern. In a patient is not being warmed. Okay, you bring in a patient to OT, you didn't put any warmer, patient is completely naked, you're not covered the patient or anything, and you induce the patient, this is what going to happen. But in real life, this not happen because we usually cover the patient, we warm the patient, we make sure the warming blanket is on, warming mattress is on, and so and so. Okay. So in the second phase, we have said heat loss exceeds heat produced from the metabolism. So what are the mechanism of heat loss under anesthesia? Okay, that brings us to this concept of this four. There are 4 to 5 main mechanism. The main is 4 lah. Okay, RCER. Bring us to number 1 is the radiation. Okay, radiation followed by your convection. Okay, followed by convection. We'll discuss what is each of these and what are the metabolism mechanism of it. Radiation, convection, then you have evaporation. Final R is respiration and conduction. Respiration and conduction usually coupled together. They are minor. They only 5%, 5%, or some book mention 10%, 5%. Doesn't matter. Okay. So 4 main mechanism is radiation, convection, evaporation and respiration slash conduction. Okay, respiration slash conduction. Let me just put it here. So respiration or in a small conduction. Okay. So these are the 5 mechanisms where you get your mechanism of heat loss under anesthesia in a perioperative period. So now we go into each of it. First, we talk about radiation. Radiation is the #1 major factor where your heat loss is occurring. Radiation accounts for 40%. So what is radiation? Is thermal radiation emit from body based on temperature and color of its surface. Mean difference between your body temperature and your room temperature. Obviously, your OT temperature is much colder than your core temperature. So the heat is lost from your, sorry, where's this picture? So the heat is lost. This is radiation. The heat is lost from your body to the environment. That is radiation. Accounts for 40%. Okay, difference between body and room temperature. If the wider is if the patient is more hot, patient is having fever, the OT temperature is even colder, more heat will get lost. Okay, that is why we make sure when the patient comes in, before they making skin incision, when you induce, you don't have to make the OT temperature very cold. You can maintain it a bit higher temperature. Once you induce, when they're painting and then before they start incision, then you can bring down the OT temperature. That is one of the advice or suggestion given in NICE guideline to prevent preoperative hypothermia. So how do we reduce the heat loss? I have given few, one shot I've put out few precautionary method or what methods we can do to reduce the heat loss via radiation is, one is making OT temperature optimal, as I mentioned. Before induction, keep it on the higher side. Before skin incision, bring it down. Because the reason why we are keeping the OT temperature low to prevent infection. Okay. Next is insulation. Okay. Cover the patient. So less heat is lost from the body. Give warm fluids. No, don't give low fluid. Because when you give warm fluid, you are making the temperature equal. And then radiant warmer. We put a warming blanket on top. So because the immediate environment on top of a body is not so cold. So patient's core temperature is not being loose. That's why we put a warming blanket on top of the patient. The warming blanket acts like a barrier between the actual OT temperature and the patient core temperature. The warming blanket is a bit more warmer compared to the OT temperature. So not much of the core temperature is being lost to the OT temperature. Okay. Next is convection. What is convection? Convection accounts for 30%. Convection is direct. It's a transfer of heat away from the object. Okay, let's say patient is lying down. Patient's heat is being lost. It goes to the immediate environment. So the immediate environment actually now a bit hotter. If it remains there, the gap between the immediate environment and patient core temperature is not that much. So no more further heat loss. But our OT as a laminar flow, the aircon, we can see our OT as a constant airflow. So this constant airflow move away. It disperses the hot air on top of the patient away. And again, there is a temperature gradient between patient core temperature and immediate environment increase. Thus, more heat is lost. That is the of using a forced air warming blanket. Okay, we want to maintain the immediate temperature around the patient is warm. Of evaporation, heat taken away from the body for the process. Okay, heat taken from the body for the process. When you have a water vapor is evaporated, the heat is lost together. It is because mainly on a moist area on surgery. That's why we don't let the surgeon, if they want if they open up the abdomen, we say please cover up, don't let it open. And unnecessary areas which is not being operated at the moment, don't let it post. That's why when the surgeon, if they're operating one side, they're going to the other side, please cover it, plug back or aluminum foil. Especially if we do this in a pediatric patient, when a neonate come from omphalocele or anything, you see they usually cover it up because the evaporative loss can be very large. Avoid unnecessary exposure, use a warm irrigation fluids. Okay, these are all methods to reduce evaporation. Because why warm irrigation fluid? As I mentioned, the evaporation depends on water vapor pressure gradient between skin and temperature. If the water vapor is warm, then the less of evaporation will occur. Next, we talk about Next, we talk about the last two components of respiration and conduction, 5%, 4%. Different resources quote a different value for all these. Some say 5, 50, 30, 20, some say 40, 30. It doesn't matter. As long you know the radiation is the highest, followed by convection, followed by evaporation, and respiration and conduction account for the lowermost. Okay. Some book mention is 15, 5, 10, 5, something like that. I just keep it as easy. 40, 30, 20 here. So I just keep it as 40, 30, 20 here to make it easy. 44, 3, 2 followed by 5, 5. Okay. So these two account for 10% lah. Okay. So what is respiration? Is evaporative heat loss on breathing. Okay. When we have breathing, we're gonna lose evaporative loss in our respiratory gases as well. That's why we use HME, low gas flow circle system, and with soda lime. Soda lime also causes exothermic reaction. It's a closed circuit. So we are not letting the heat to loose from our circuit. Next, conduction. Conduction is direct transfer of heat between two objects in contact. Okay, that's why we always place a linen on top of the OT table before the patient lie down, because the OT table, the steel, the bed, everything can be cold. If the patient's body directly touches it, there'll be direct heat transfer. And if there is a linen that is wet, the surgeon using if it's washing lead, we usually change it, because when if it's wet and it's cold, the direct heat transfer will occur from the patient body to the object in contact. So avoid cold metal objects contact, use warming mattress, remove the wet linen. That's why even when the arm by side on the arm board, we usually put a blue sheet or we put a green linen to cover it up, because we don't want the patient's body directly in contact with an object. So this is the pyramid where we know radiation, conduction, evaporation, finally conduction and respiration comes here. Okay, this is the pyramid. The highest is radiation, 40, 30, 20, finally conduction, respiration, 5%. Okay, you should be able to mention the mechanism or heat loss when few methods to prevent it. Okay, that is what important. Next, the heat loss under NS different based on general anesthesia versus regional anesthesia versus combined. Of course, this is in a patient with, first look at the GA alone. Okay, GA alone follows the curve that we mentioned just now. This is the graph if we are not warming up the patient. This brings us back to this concept. Okay, it brings us back to this concept. Okay, this is general anesthesia. Heat loss under general anesthesia alone. Okay, so in comparison with that, how does regional anesthesia differs? So when we look at it, this is the patient under general anesthesia. If you are giving regional anesthesia alone, epidural or spinal alone, of course, the heat loss is much, much lower. Okay, because as we say, the general anesthesia, the redistribution because of the intravenous anesthetic agent and all the other factors causes more. Okay. But when you have GA plus epidural, let's say you're doing a gynae surgery, TEPSO, radical hysterectomy or whatever, so you're giving epidural on top, after that you're GA patient. So your regional anesthesia abolishing or sympathetic effect and so on. Plus on top of that, which is gross adaptation and redistribution for temperature free. So epidural GA plus RA causes more heat loss compared to GA alone compared to RA alone. So you should be able to, they might ask you to compare. You just have to draw the first one here. Then you draw another similar one on top and then another one. If you look at GA plus epidural, it doesn't reach the plateau much, It takes very long time to reach plateau. That's why if you're giving GA plus epidural, make sure the patient is properly warmed before you give your epidural and also before you induce the patient. Okay, don't make, because the moment you give epidural, patient already have peripheral vasodilatation, or spinal patient already have peripheral vasodilatation ready. And after that, you're going to put the patient into induction and cause more peripheral vasodilatation, and redistribution going to be very severe and drop of temperature. Even the first period will be very high. This is just a repetition of it. So if you look at it, GA plus RA, the temperature does not plateau because vasoconstrictor mechanism by impaired by sympathetic block. This is the sympathetic block by your RA. Okay, so the plateau reaches even at a later period. It takes longer time for the thermoregulatory mechanism get activated on its own. Okay. I will share this thing. This is from NICE guideline. This is actually for finals. I read it for finals. I kept it. Strategies for the prevention of inadvertent perioperative hypothermia. IPH for inadvertent perioperative hypothermia. I will share this later. This is, you can use it for day-to-day work as well. This is actually, I've summarized all this in my here, all these things, okay, what we do. But that is the few things that can be do to prevent hypothermia, be pre-op, intra-op, and post-op. Next, how to warm the patient. Warming the hypothermic patient, you can divide it into non-invasive and invasive method, or active and passive method. Okay, non-invasive is ensure the surrounding is dry. It means like linen. Make sure the bed is not wet and everything. Cover the skin. That's why we sometimes use autobahn to cover the patient, and then we use some in kids we use the plastic bag. Cover or close wounds. Don't unnecessarily expose it. Raise the ambient temperature. The OT temperature should be on the higher side before induction, before skin incision. Radiant warmer, forced air warmer, and then invasive is what goes inside the body. This is all outside the body externally. Then what inside, you can do a warm IV fluids. This is active, very invasive in a patient who are severely hypothermic, let's say drowning patient, everything. You can do a luminal lavage with warm fluid, hemodialysis or hemofiltration. You can even, or cardiopulmonary bypass in a severely drowning patient and everything. Like this ALS method lah. Okay, this is in an extensive mechanism, extreme. Okay, in a simple mechanism, I have already mentioned the methods here, what we can do and everything. HME all, it actually do a very good mechanism in preventing this 5%. These are simple things we can do without any extensive things. All the simple thing. When you give a blood, make sure you use the warmer, fluid warmer, the machine, so it does not give a cold fluid inside the body and everything. All these are very simple mechanism we can do. Okay. That's about temperature. Finally, a little bit on temperature measurement can be asked in Viva as well. So the methods of temperature measurement, it divided into non-electrical, where you have alcohol and mercury thermometer, works on the principle of liquid expansion, and we have dial thermometer, which works on a gas expansion. We have a bimetallic strip, which is used in your vaporizer and everything, and you have a Bourdon gauge, which is used in a pressure regulators and a oxygen tank and everything sometimes. Next, you have an electrical measurement using example would be the resistant thermometer, thermistor, and thermocouples. Okay, resistant thermometer, thermistor, and thermocouples. And finally, you have infrared base, which is the easiest one, tympanic membrane thermometer, the one we usually use in our ear, used in OTs and ward and everything. Okay, the mercury thermometer is the one we put under the tongue or inserted into your rectal and everything lah. Okay, the thermistor is the one that we use, a small one that we put at the axilla, or we're gonna put it into our rectal as well. All these things. So I'm not gonna discuss in depth about all these things. Terry Brandeis have explained very easily among all these things, and you can refer to podcasts also. That is more than enough for temperature measurement. You don't need to know anything more than that. What can be asked regarding electrical thermometer is this graph, which is this is for resistant thermometer, where your temperature change is directly proportional to resistance change, like ohm. Resistance is ohm, okay, Ohm's law. Then in a thermistor, it is inversely, the resistance is inversely proportional to the temperature, and thermocouple also directly resistant. But for resistant thermometer, there is a lag point. It doesn't start from 0, whereas for thermocouple, it starts from 0. I'm not going to explain this graph. You can read about this in podcast. They have these graphs are taken from podcast primary as well, and they've explained very briefly and what is important and needed for Viva. Okay, you should be able to draw this thing and explain the principle. This one, resistant, directly proportional to temperature change. This is inversely proportional. This is also directly proportional, but the resistant thermometer does not start from 0 for a specific reason, where thermocouple start from a reason. And then you must know where these are used. Okay, few examples. And temperature monitoring side, where the core temperature is being monitored, the best is pulmonary artery by putting a pulmonary artery catheter. Distal esophagus is okay. We can have a distal esophageal manometry that we can put in a temperature probe as well. Then tympanic membrane is the one that usually we use, or we put a nasopharynx that we insert in our OT setting as well. These all measures core temperature. Okay, peripheral temperature or not core intermediate sites, it's oral, rectum, and bladder. This is under the tongue, when we rectum, when we bladder and everything. So not reliable during rapid thermal perfusion. core temperatures are reliable even during extreme thermal turbulation, means extreme fluctuation of temperature also it can be measured. And finally, the one we measured outside is by your considerably lower than core temperature is your skin temperature, okay, which we monitor by our skin temperature, with the axilla and everything. So this is skin surface. So this is temperature monitoring side. Okay, that's all about temperature. We're gonna go into cardiac output monitoring. As for primary, you just have to know the principles and examples of cardiac output monitoring. The details of it, it's more into finals. Okay, it's all bring back to this concept of MAP equal to cardiac output times stroke volume times systemic vascular and we know cardiac output is stroke volume times heart rate. So finally, your BP is stroke volume times heart rate times your systemic vascular resistance. So it's all about maintaining your MAP. All these are repetition. I'll run through very fast. We talked about it. Okay, and we know your stroke volume is dependent on your afterload, preload, and contractility. Okay, all this repetition, and your usual hemodynamic monitoring can depends on the device you use. It can give multiple parameters. The one that we very usually that we are very focused on is your stroke volume, your cardiac index. We want to know about your systemic vascular resistance. It can give your some of the extensive one can have a inbuilt algorithm to give your ejection fraction as well. Okay. So something with the derived parameter, when you put in your HB, when you put in your PaO2, it can calculate your oxygen delivery values as well. So the methods, the will be, can you tell me few methods of cardiac output monitoring or advanced hemodynamic monitoring? The most invasive one will be your PA catheter, okay, pulmonary artery catheter or Swan gun catheter. A less invasive method would use a transpulmonary dilution, PICO or LITCO, lithium dilution cardiac output, PICO pulse contour cardiac output. And we have a pulse analysis or pressure variation, flow track with it. Then we have ultrasound Doppler using a transesophageal echo or esophageal Doppler. These are less invasive. They still goes inside your body, but less invasive. And not thoracic, all these also advanced hemodynamic monitoring parameters as well. Okay. So this is your flow track. We have seen for sure. This is most care. These are all pulse contour analysis, which is more commonly used in our setting. Okay, pulmonary artery catheter only used in a cardiac setting or cardiac lab or cardiothoracic units. Most of the time now we move on to transpulmonary dilution, also more invasive. PICO all it actually uses a lot of invasive method and a lot of sterility and expertise needed. So usually people are going for these two. Okay, pulse analysis method or ultrasound Doppler method or ultrasound based ASCOM. Okay, less invasive method nowadays. Flow track, this is most care, this is ASCOM. So this one I will share later. This is just advantages versus disadvantages of each mechanism. I will share this. This is more into final now. Okay, as you're able to say this actually again this classify it based on invasive, less invasive, and non-invasive methods. This is also again the differences and the good and bad of each system. I will share it later. Okay, now we go to the principles. What is the principle behind the advanced hemodynamic monitoring? First, you have two equations, Ficks principal equation and Stewart-Hamilton equation. This will be asked in your level. We have talked about this during our oxygen delivery classes previously. Those who haven't watched it, please go and watch the recording about your oxygen delivery. How do I calculate the VO2 and DO2? Okay, oxygen flux and everything. So here, the Ficks principle, it's all about what goes in must come out. Okay, if it doesn't equal what goes in, the same amount must come out. If the same amount didn't come out, the differences is what has been consumed. Okay, in Ficks principle, we uses oxygen as a parameter to calculate your cardiac output. So your cardiac output is oxygen consumption, okay, flux VO2, oxygen consumption divided by arteriovenous oxygen difference. Your CaO2, arterial oxygen content minus your venous oxygen content. Okay, the differences of it is your oxygen consumption, the flux. Flux is your delivery. Okay, and the Stewart-Hamilton equation actually equates to this as well. Okay, it also talks about volume of a marker can be calculated if mass and concentration measured. So if concentration is measured over time, then flow can be calculated. Okay, it's all talking about volume divide equal to mass over concentration, and this is the Stewart-Hamilton equation punya thermodilution curve. This is the part you inject, the temperature will go up and the temperature will come down. This is the measured thermodilution. Area under the curve will be your cardiac output measurement. Okay. Oxygen or another marker such as dye can be used by the Ficks principle to calculate cardiac output. The Stewart-Hamilton equation is a modified version of this principle that calculates cardiac output using temperature change. Okay. Both are visually represented in this diagram. So principle for key equation principle, blood flow to an organ equal to rate of uptake of oxygen or substance divided by arteriovenous concentration difference. Okay, how much has been taken divided by the differences. Q equal to M divided by A minus V, where Q is the blood flow, how much of cardiac output is going into the organ per minute. M is the number of moles of substance added or removed, the marker we use. Okay, in here the marker would be oxygen. Okay, VO2. A is the arterial concentration and V is the venous concentration of the substance. Uptake or excretion of a substance by organ must be equal to difference between amount of substance entering and amount of substance leaving the organ. Amount entering is the arterial flow times arterial concentration, CaO2. Okay, the blood flow times the, in case of oxygen, the blood flow that goes into your blood flow is your cardiac output times your arterial concentration oxygen. This is your oxygen delivery. Amount leaving is venous flow times venous concentration is how much oxygen is being returned to the heart. So this is venous flow, this is arterial flow, this is venous flow. Rate of uptake is the amount that is being consumed. So if you rearrange all that, your cardiac output Q will be equivalent to the consumed method, how much is consumed, divided by the arteriovenous differences. It goes back to the same equation. So we have talked about this in our previous classes. The Ficks principle, we have to know oxygen consumption, we have to know the oxygen delivery, then we have to know the oxygen content of CaO2, CbO2. Differences between these is your AV minus difference, then you can calculate your cardiac output. Okay, then you can calculate your cardiac output. So for how do we calculate the oxygen content in blood? For arterial and venous, we have talked about the oxygen consumption equation. We have to calculate oxygen carried by the hemoglobin and oxygen is dissolved in plasma. I'm not going into depth of it. We have discussed this few times before. How do we calculate oxygen delivery? Oxygen delivery is once you calculate this oxygen content, you're gonna times with your cardiac output. That will be your oxygen flux, oxygen delivery. Okay. Stewart-Hamilton equation is a derivative from the Ficks principle where it uses a thermodilution technique. Here uses the temperature change thermodilution technique. So it is a derivation from the Ficks principle. It is used in a PA catheter or PICO. Cardiac output is equal to the amount of indicator injected divided by the average concentration in arterial blood. Okay, this is the cardiac output equal to amount of indicator divided by area under dilution curve. You have to know this equation, and sometimes if you're able to tell this equation, memang distinction lah. Okay, I don't even remember this. If you're able to tell this and you're able to draw this graph and you can see this area under the curve and amount of injector, then you can able to answer. Okay, the definition of terms used here is the cardiac output, CO, V injected is the volume of injected. So it means how much of the water, the cold water is injected, is the volume injected here. This is all a bit too technical. I'm not going into depth of it. This is just a revision class. Okay, so as long you have know this equation and you can able to tell this graph, is more than enough. Stewart-Hamilton is a derivation of Ficks principle. Please remember. This is your thermodilution using a PA catheter. We'll talk about PA catheter. Okay, in PA catheter, what happens is the cold injectant is introduced into the right atrium. You inject a cold injectant, okay, to right atrium through a proximal port of pulmonary artery. So you inject here. Next, the cold injected will reach your right atrium. The injectant solution mixed completely with the blood with the right ventricle, from right atrium to go to the right ventricle, and then from right ventricle goes into your pulmonary artery. The cool blood then flows into the pulmonary artery and the thermistor. Your pulmonary catheter will have a thermistor. Just now we talked about electrical way of measuring temperature, right? So thermistor is one of the electrical way of measuring temperature, which is embedded in the pulmonary artery tip. Okay, it can register the temperature change because before the cold injected come, the blood in the pulmonary artery will be very warm, calm temperature. So the thermistor would have measured that temperature. And then when we inject a cold injected, the cold water from right atrium go to right ventricle and reaches the pulmonary artery. It will cool down the blood and then reduce the temperature from high to low. That is where the temperature change will happen over the thermodilution graph. Okay. This is PICO. PICO uses the same way method as well, transpulmonary thermodilution. I'm not going into depth of it. This is the PICO. It's almost the same. Okay, it's just that from here, instead of pulmonary artery catheter, they use central venous catheter and arterial catheter. Okay, it's just a different device, but the concept is the same. That brings us to thermodilution, pulmonary artery catheter. Very briefly, you have to know PA catheter anatomy. It's a flow directed. All these are keyword. It's a flow directed device. It measures pulmonary capillary wedge pressure, pulmonary artery occlusion pressure, which is equivalent to mean LAP, equivalent to left ventricular end diastolic pressure. My tutorial on this has been uploaded under UITM tutorial. Those who wanted to watch a full tutorial on PA catheter can watch that. I've explained extensively there. Okay, it is usually 110 centimeter long and its size is 5 gauge to 8 gauge. It has a multiple lumen at 10 centimeter interval. There is 10 centimeter marker. There is a multiple lumen. At the end, 4 centimeter from the tip, there is a thermistor. Okay, that is to measure the temperature change. It measures thermoregulatory cardiac output measurement. It is a thermodilatory cardiac output measurement using a Ficks principle. Will only be accurate if in West Zone 3. So when we put in a pulmonary artery catheter, it has to be guided by TOE, and then we have to confirm with chest X-ray to make sure it is in a proper zone. This is the pulmonary artery where your pulmonary artery pressure is more than pulmonary venous versus pulmonary airway. Okay, PA more than PV over airway. So this is just an extra information. If the airway pressure is high, it becomes zone 1, and then it will be a bit accurate. It has to be zone 3. These are few pressures. I'm not going into this. I will just, this graph, you must be know. You have to be able to draw this graph as the pulmonary artery catheter move from your right atrium to right ventricle to pulmonary artery. Finally, when you wedge the your pulmonary artery catheter. At the right atrium, the pressure is usually 0 to 12 millimeter mercury. So it's wingle around there. It's very low. Then once it reaches your right ventricle, it goes to 2 to 25 millimeter mercury, 2 to 25 millimeter mercury. Then once it reaches pulmonary artery, it will be 12 to 25. Then finally, once you wedge it means you inflate the balloon. So you see, this is your catheter. If you go further inside, this is zone 3. Okay, when it goes into your further into your pulmonary artery and you wedge it, then it becomes your pulmonary artery occlusion pressure, where it is 8 to 12. These values you may need to know. Okay, right atrium up to your occlusion pressure. So your pulmonary artery occlusion pressure is equivalent to pulmonary capillary wedge pressure, which resembles your left atrial pressure. Okay, it is a indirect measurement of your left atrial pressure. Again, these are just repetition. Okay, how to measure, not important. What can be measured? How do we measure pulmonary capillary wedge pressure? In an intubated patient, we measured end expiration. In a spontaneous patient, end expiration. This is all extra information. What is being monitored using a pulmonary artery catheter? We have a continuous versus intermittent measurement. Continuous, we have a pulmonary artery pressure, SpO2 and temperature. All these can be measured. We can measure core temperature of the patient. We can ask a pulmonary artery pressure. When you intermittently, you inflate the balloon, you will get a pulmonary artery occlusion pressure, and then you can do a thermodilution technique to measure cardiac output. So it's continuous versus intermittent. The discrepancy, I will share this later. This is in case they ask, but unlikely, I think. The contraindication, you must know the same contraindication as goes to any central catheter, plus a few more when a patient with lung issues. Okay. Cardiac output measurement, Ficks Law, again coming back to the same thing. This is just a summary of it. Okay, for you to calculate your cardiac output, you must have this information. Okay, this is Ficks principle. I have another around 20 to 40 slide on recap of all this, but I don't think we can do it today. It's quite a lot, like it's on ECG and everything. I've done these classes with UITM. There's UITM tutorial and all these things about ECG, Artline, and mostly ECG and Artline. Those are the two main things. But I'm not going through it today. It's already 1 hour.